seniors and Medicare?
Absolutely.
Did the administration oppose H.R. 3?
We do oppose H.R. 3.
Did the administration support the concepts of H.R. 19, our alternative?
We support the elements of it, absolutely, including the notion of capping out-of-pockets and saving seniors money.
One of the big issues we've dealt with here, or tried to, is the high cost of insulin. Not just for seniors, but for others. But in our alternative, H.R. 19, that was all bipartisan legislation, we capped cost of insulin, I believe, at $50 a month was the maximum. Does the administration support that concept?
I believe so, yes.
So going forward, are you hopeful that the Congress and the administration can get together on a plan the president can sign that can become law that would actually reduce the costs of pharmaceutical drugs in America without driving innovation away?
Yes, I have said the administration is the most flexible party here. Republicans, Democrats, Senate, House, get list prices under control, lower out-of-pockets, and give the drug plans the real incentive to get drug prices down. H.R.
19 contains about 80 or 90% of the Wyden-Grassley bill. We think we're with you. We think we can get there if we can just put the partisan weapons away. Thank you, Mr. Secretary, and I yield back.
Gentleman yields back. Pleasure to recognize the gentleman from New York, Mr. Engel, for his, is it 4 minutes? 4 minutes of questions.
Thank you, Madam Chair. Secretary Azar, the state of New York was extremely disappointed to hear that CMS has denied the state's request for a renewal of its delivery system reform incentive payment program known as DSRIP. When the program was first approved, CMS and HHS insisted that New York include targets for the state's Medicaid program that would incentivize providers to move away from fee-for-service toward value-based payments. New York's health care community has made progress in doing just that, receiving double-digit reductions in preventable hospital readmissions while saving the federal government billions of dollars. The request for additional time and continued investment of those savings in DSRIP was to move closer to exactly what CMS and HHS have been saying the federal government wants everyone to be doing. So in light of that, why would CMS and HHS want to stop supporting these successful efforts to achieve the very goals that the Trump administration has been saying that it has for health care? So will your department commit to meeting with the state of New York to discuss how these reforms are sustained into the future? I'd like a yes or no answer if I could get it.
Yes, I'm not familiar with that particular program, but you're right, we do support value-based transformation in our programs. I don't know the particulars of why CMS has had difficulty with New York, but yes, we'll be happy to sit with New York.
Okay, and I'd be happy to sit with you as well.
Thank you.
Discuss it. Mr. Secretary, we've mentioned it here, other members have mentioned it here, and you know it far too well, that Americans are suffering from the current epidemic of skyrocketing prescription drug prices. My constituents always tell me they're having to make unconscionable choices between paying for food or filling a life-saving prescription such as insulin. The House has taken bold, decisive action to lower drug prices through H.R. 3, which provides a common-sense solution to this crisis by allowing the government to negotiate drug prices. That's a policy that the President supported as a candidate in 2016, saying, and I quote, "When it comes to negotiate the costs of drugs, we are going to negotiate like crazy," unquote. That's from the President. The administration has yet to deliver any meaningful solutions for the health crisis. In May 2018, your department released a blueprint to lower drug prices, but many of those policies failed to materialize or provide minimal relief to patients. Other ideas, such as the International Pricing Index, has been shelved. Despite these failures, President Trump claims to have reduced drug prices, when in fact a recent report showed that on average, drug prices increased by over 5% at the start of this year. So, Mr. Secretary, can you commit to me today that you will deliver on the President's promise to negotiate drug prices? I'd like a yes or no also.
So we support bicameral, bipartisan legislation that would get through, and there are many principles in H.R. 3 the President is supportive of, but it has to pass both houses of Congress. And at the moment, H.R. 3 doesn't have a chance of seeing the light of day in the Senate, and so we need to work together to see if something can get through both chambers.
Well, I'm sure if the President asked Mitch McConnell to put it on the agenda, he would.
I don't think so.
there are plenty of things that we've passed in this House that unfortunately the other body hasn't done, and the President seems to be right along with it. So I just think it's another example of the administration's broken health care promises to the American people. I just think that we need to get those prices of drugs down, and we need to have not empty rhetoric, but true facts. And I yield back the balance of my time.
The gentleman yields back. Pleased to recognize the gentleman who was the former chairman of the full committee, Mr. Upton of Michigan, for his 4 minutes.
Thank you, Madam Chair. Mr. Secretary, welcome. Big time. So as you know, this committee on a unanimous vote passed 21st Century Cures as we call it, when I was chair. We expedited the approval of drugs and devices, and I would suspect strongly that your testimony that we had a record number of generic approvals is a direct result because of what this committee did. We also added some $45 billion in health research over a 10-year span. And frankly, we asked the question of the agencies as we worked on this legislation, what is it that we could do to help you make sure that we hit these targets of faster approvals of drugs and devices? And so whether it was the FDA, the CDC, and others, the NIH, obviously, they gave us an answer, and we delivered. And at the end of the day, for this crisis, we are going to find a vaccine to solve coronavirus. I know that we are, and I'd like to think that what we did in this committee and then passed on the House floor will be a direct result of that. And frankly, it prompts all of us, I think, to ask the questions of what more can we do to get on a faster pace to find that vaccine and that cure. And in fact, as you may know, Diana DeGette and I are again working on a 2.0 cures bill where we can take these 3 years since President Obama signed the bill into law and ask those questions to see what constructively we can do so that all hands are on deck. And I know, don't have to ask you, I know that you will help us with ideas to do that. Question that I have is a containment in the very first step in responding to any outbreak of coronavirus. We've seen that around the world now. And statements from yesterday indicate that the CDC said it really isn't if, but when it gets to a larger numbers here in the United States. I've always believed in the adage that if you're going to do something, better do it right the first time because you're not going to find a second. And and you want to make sure that pay me now or pay me later. So we need to have the right numbers as it relates to fighting this terrible disease. Is the $2.5 billion, is that a floor? Is that a suggestion, the $2.5 billion that you requested?
We have described the request as at least $2.5 billion for 2020 money, and then work on 2021 money as we see the situation develop over the weeks and months ahead.
So I know that we're waiting for the precise details of where it's going. Are any of those dollars envisioned to include the contingency of what China has done as it relates to regional quarantines?
No, we don't envision that as a kind of practical step here in the United States. That we would, as Dr. Messonnier spoke about yesterday, in the event that we had community-level outbreaks, which might be small, just a town, a city, if we had that, we would take the pandemic playbook, which is community-based mitigation steps, social distancing. It is very rare that those types of cordon sanitaire efforts around cities they are effective. They usually provoke more panic and cause people to actually leave and spread. Now, China's a different government and culture than we have here.
Of the 14,000 Americans that have died this flu season, do you know what percentage of those were not vaccinated?
I do not have the numbers. Historically, our youth who die tend to not to have been vaccinated, which is a real tragedy.
And the last question, there been any query of those 55 Americans who currently have been diagnosed with the coronavirus? Did any of them have the flu vaccine? Do you know, was that question asked of any of the 55?
I don't know that would have been asked. We don't, of course, have any evidence that the flu vaccine would have any properties related to the novel coronavirus, but I don't know if that was asked as part of intake for the patients.
Okay. I yield back.
Gentleman yields back. It's a pleasure to recognize the gentlewoman from California, Ms. Matsui, for her 4 minutes of questions.
Thank you, Madam Chair, and for holding this important hearing, and welcome, Mr. Secretary. Before getting to my line of questioning, I do want to express my deepest concerns about the Medicare, Medicaid, and other cuts included in the budget. At a time when we're dealing with the coronavirus outbreak, an addiction crisis, and a lawsuit that threatens ACA protections for pre-existing conditions, the administration's cuts to critical safety net programs target the most vulnerable in our communities and aim to further erode access to vital health care services. We should be prioritizing primary comprehensive care, particularly in the mentally ill and people with addiction. I believe mental health is an area where we have an opportunity to work together and make progress. Mr. Secretary, I appreciate the department's strong support of the Certified Community Behavioral Health Clinic Medicaid demonstration. As you know, Representative Mark McMullen and I are working to further scale the program with our bipartisan legislation, the Excellence in Mental Health and Addiction Treatment Expansion Act. For the 8 states currently participating in the Excellence demonstration, we have studies showing that quality mental health services, outpatient care, and addiction treatment provided at these facilities are saving lives and money. People are avoiding jails and emergency rooms, instead getting the comprehensive care they need in their communities. We have 11 additional states that are ready to participate in an expanded excellence program. Our bill has a bipartisan group of 88 co-sponsors who support this full expansion, and the House has already voted to extend the program longer term. I was very pleased to see that the budget this year explicitly endorses extending the excellence demonstration, and I believe we do all agree, Mr. Secretary, that adequate Medicaid resources around substance abuse treatment are essential to fighting the opioid and addiction epidemic. Mr. Secretary, I have a question. Under the leadership of Chair DeLauro's $200 million was made available to HHS in FY20 to help states prepare for eventual participation in the excellence demonstration. How does HHS plan to obligate these resources?
First, thank you for your personal leadership on the Certified Community Behavioral Health Center issue. That is, you're right, the data is showing really positive results to date, so thank you for that. In terms of your work with Chairwoman DeLauro, SAMHSA is now accepting applications from states for these grants to increase access to and improve the quality of community mental and substance use disorder treatment services through the expansion of CCBHCs. And the deadline for states to apply is March 10th.
Okay, thank you. The positive impacts of the demonstration make it clear that there's room to improve mental health and addiction care in this country by scaling this program. In California, our county hospitals, public academic medical centers, and public children's hospitals rely upon financial arrangements that leverage public funds and partnerships as essential means of providing health care to the most underserved communities and patient populations in the state. I have concerns about the administration's recent proposal to eliminate these sources of funding, particularly supplement payments. I worry that if finalized, the Medicaid accountability rule will destabilize the whole system of care provided under Medi-Cal. Medicaid supplemental payments are an integral component of total Medicaid reimbursement that providers rely on for adequate reimbursement and financial stability. Mr. Secretary, have you weighed the restrictions on supplemental payments against the adequacy of these base payments? Are there plans to make any corresponding adjustments to base payments for these providers?
So we're hearing the very important feedback from you and others about that regulation, and we want to take that in as we look at how and whether to finalize at CMS on the relationship of these intergovernmental transfers to supplemental payments, and also if there are ways we can work with states to restructure payments in a way that would be consistent with the law. So we want to work with the states, not be adversarial to them on this.
Okay, but thank you, Mr. Secretary, and I yield back.
Gentlewoman yields back. Pleasure to recognize Mr. Shimkus of Illinois for his 4 minutes of questions.
Thank you, Madam Chairman. Thank you, Mr. Secretary, for being here. Coronavirus is a novel pathogen, as a lot of us know. But in your testimony, you also mentioned emerging microbial threats. And Madam Chairman, I'd like to ask to submit in the record this this news release from the World Health Organization on the 17th of January, 2020.
So ordered.
And in the 114th Congress, I joined with Gene Green on what we called the ADAPT Act. Last Congress, it was Tony Cardenas and I, with the help of the now chairman of the subcommittee, Anna Eshoo, who joined, and technical assistance by HHS on what we call the Revamp Act. And it's an attempt to address how, if you have these antimicrobial resistance, how public funding may not be the only way you can address this. Can you talk about that challenge?
Yeah, I'm very concerned about the drug development around antimicrobial resistance in terms of creating a sustainable market. You know, we've had actually tremendous success from the efforts you've led and the Congress has led and BARDA at my agency have supported. We've supported development of 16 novel antibacterial projects. I believe 3 have actually come to market. What we're finding, though, is there's a market failure question here where you're basically asking a company to develop a drug, but then not to have it used much. And that's not a usually sustainable business model. So I've actually commissioned my team to work on how can we possibly solve that? Is that more like a bioterrorism chemical countermeasure and the approaches that we need there? Quite concerned about this situation.
And that's what we've tried to do legislatively, and at some time one was the tradable vouchers debate, which I think still should have legs, especially in this concern of, as you put it, trying to have something on the shelf that you don't want to use. That's the key. Scott Peters and I are also working on legislation that we call Ending the Diagnostic Odyssey, and it is an attempt to help DNA sequencing so that when there's a disease or some event, you don't have to test. You can go just through the sequencing aspect of that. Any thoughts on or comments of what you all may be doing that we don't know about in trying to push more DNA identification?
So I've not studied that particular issue. We're happy to get back to you on that. It certainly is at the fore right now as we deal with novel coronavirus and have the CDC diagnostic, but also hope that commercial innovators will develop physician bedside diagnostics for rapid in-site testing.
Yeah, and this is timely. Well, obviously it's timely because of the threat that we're all concerned about now, but it's also Rare Disease Week, and a lot of that community is looking for this as a novel way, especially on that, what we call that diagnostic odyssey, where they just, and we see that with people who are struggling with just types of cancer and trying to identify the right treatment early versus what I would say sometimes is a trial and error method that is very damaging to the health of the patient. And with 30 seconds left, I wanted to just briefly, and it's been asked a little bit before, you all do support Medicare D reform, is that correct?
Oh, absolutely. It's a real opportunity for seniors.
And how would reform lower patient out-of-pocket costs?
Well, you would cap catastrophic payment at the limit at $3,100. So a patient would never pay more than $3,100. And then at least the Grassley-Wyden plan, the senior could actually opt into a program where they would pay no more than $258 a month for their drugs, no matter what their expenses are.
Amen.
Gentleman yields back. The gentleman from Maryland, Mr. Sarbanes, is recognized for his 4 minutes of questions.
Thank you, Madam Chair. Secretary Azar, you certainly know that the popularity of e-cigarettes has recently led to an unprecedented surge in youth tobacco use, and it's bringing back with a vengeance the tobacco epidemic in this country we've worked so hard to curb. It shows why we have to improve the law, and something that this committee has been working on. Unfortunately, the Trump administration is now proposing, as I understand it from the budget, removing FDA's oversight of tobacco products in favor of an untested agency that will take years to get off the ground, which threatens to set us back even further. I'm perplexed that the administration would decide to do this, remove FDA's authority, alter the agency's public health mission, which includes making, quote, tobacco-related death and disease part of America's past, not America's future, and by doing so, ensuring a healthier life for every family. This latest move is kind of breathtaking. It makes no sense. It's a crazy thing to do by the administration, which unfortunately hasn't taken significant action against big tobacco as more of our nation's youth are becoming addicted. In January, after heavy lobbying from big tobacco, as we understand it, and the vaping industry, and listening to partisan political consultants like Trump campaign manager Brad Parscale, the administration reversed course, and we were on a trajectory where we thought everybody was on the same page. The administration reversed course, announced a policy which failed to ban all flavored e-cigarettes, allowing popular menthol cartridges to stay on the market, and allowing all flavored disposable e-cigarettes and open-tank e-cigarettes to proliferate through our nation's schoolyards, which is exactly what they're doing. And I'm concerned that removing this authority from the FDA, which is part of the proposal, could lead to even more loopholes and more industry influence. My question is this: when formulating the budget proposal to remove the FDA's tobacco oversight authority, did you, your agency's staff, White House staff, or staff of the Office of Management and Budget speak or meet with any lobbyists or other representatives of the tobacco industry, or for that matter, political operatives who work for or are contracted by the president's reelection campaign?
Well, I can't speak for others. I'm not aware of any such deliberations. The idea was that if we move the Tobacco Center out from under FDA, first, if it were a presidential appointed Senate confirmed leader, they'd be more accountable to Congress. Second, as a direct report to me or whoever is secretary, elevating the role of tobacco control there. It has always been a little bit of an odd connection. FDA is about safe and effective, whereas the Tobacco Center is about regulating a product that is undeniably bad. And so there's a...
It doesn't make any sense, does it?
Well, it would, of course, be subject to Congress if it was something you all were
we're at the height of we're at this tipping point on this epidemic when it comes to vaping. I mean, there does reside, however you want to carve up what you consider the appropriate mission of the FDA to be. There certainly resides within FDA now significant expertise and experience in terms of dealing with this issue. Why you would propose at this moment in time, when this epidemic risks, in a sense, overtaking the dimensions of the previous tobacco epidemic that we saw in this country, by zeroing out that authority and moving it to an untested new agency, which, by the way, I think would be more susceptible to political influence of the kind I was just recounting than it is now. It doesn't make any sense to me. I urge you to reconsider that. We are in the midst of this crisis, and we have to use every tool available to us here in the government to respond to it. With that, I yield back.
The gentleman yields back. There is 5 minutes and 22 seconds left on the clock. Any member that would like to leave to vote, when we get to, you can leave now. When the clock goes to 0, they will hold the vote open for those that have not arrived from our subcommittee, and at that point, we'll take a 20-minute break. But now I'd like to recognize the gentleman from Kentucky, Mr. Guthrie, for his 4 minutes of questions.
Thank you, Mr. Secretary. I look forward to getting into the coronavirus. I'm going to do that my second round of questions. So the SUPPORT Act we passed last year included my bill, the Comprehensive Opioid Recoveries Act, to establish treatment centers that offer FDA-approved medication-assisted treatments, all of them comprehensively. Currently, SAMHSA has the grant application open for entities to apply, and I'm glad HHS is moving fast on implementing the program. But my question is, how is HHS implementing other parts of the SUPPORT Act, and does HHS conduct any oversight on how the funds are actually being used?
So first, thank you for the SUPPORT Act, and it is so comprehensive. We actually established a SUPPORT Act Implementation Leadership Committee to track all of the different work streams needed under the SUPPORT Act. It's really enhancing our work across all 5 elements of our strategy on opioids, and so we're driving forward, making progress on the opioid epidemic. We got the overdose deaths are down for the first time in decades as a result of our collaborative bipartisan efforts here. And we're implementing and using the SUPPORT Act authorities, so thank you for those.
Okay, thank you. And also in 2018, Congress passed my bill, the Bipartisan Bold Infrastructure for Alzheimer's Act. Can you please provide an update on how this law is being implemented across the country?
So with that act, I'd want to, if I could get back to you in writing on that. I don't have all the details on that particular program. I apologize, but if I could get back to you.
Okay, thank you. And then this is kind of technical for my role as ranking Republican on the O&I subcommittee for this committee. And this committee and O&I conducted extensive oversight, cybersecurity at HHS, including through technical audits conducted by GAO of cybersecurity controls at HHS operational divisions. So I said it's very technical. Last Congress, the Subcommittee on Oversight and Investigations held a closed hearing in part because HHS failed to properly identify and address certain vulnerabilities. We recently received preliminary results from the most recent audit of another HHS agency, though I can't go into details in this setting. So my question is, does HHS have a point person who coordinates corrective actions on cybersecurity among all HHS agencies? And if so, we direct that person to continue to work with the committee on improving enterprise cybersecurity at HHS and ensuring that mitigations applied in one setting are consequently applied through all of HHS.
Yes, we do. Our Chief Information Officer, Jose Arrieta, who works directly with me, absolutely is in charge of those issues. If I could go back to your previous question, I'd misheard on the BOLD Act.
On BOLD Act, yes.
So I apologize on that. For fiscal year 2020, CDC will have two funding opportunities to carry out actions under the BOLD Act. So first, there'll be the public health programs to address Alzheimer's disease and related dementias. And second, there will be the health centers of excellence to address Alzheimer's disease and related dementias. We expect both of those funding opportunities to be out in the coming month. And for FY 2021, the President's budget for CDC includes $3.493 million to continue to support these Alzheimer's activities.
Because by 2050, that's when I'll be 86, I believe, they believe it's going to be estimate CBO, $1 trillion spent on Alzheimer's disease. Not only is it devastating to the individual who has it, the family that cares for that person, but also it'd be devastating to the deficit in the budget of our country. So this is something very important. Thanks for your leadership and effort, and I appreciate working with my colleagues here to move the BOLD Act forward and address it. And I yield back.
Gentleman yields back. Pleasure to recognize the gentleman from New Mexico, Mr. Lujan, for his 4 minutes. And I'll wait right here with you, and then we'll run over.
Thank you, Madam Chair. Secretary Azar, when Donald Trump was running for office 4 years ago, he famously said that he wouldn't cut Medicaid. He didn't say it once or twice, but claimed it at least 5 separate occasions that he would not cut Medicaid. But in reality, no president and no administration in the last 50 years has done more to undermine Medicaid than Donald Trump. In fact, his first major legislative effort to repeal the Affordable Care Act would have ended Medicaid as we know it and put the health care of 70 million Americans at risk. And if my colleagues from the other side of the aisle want to protect people with pre-existing conditions, they should drop the lawsuit. That could happen tomorrow. After President Trump failed to cut Medicaid legislatively, he decided to try the same thing administratively, even though the law clearly does not allow it. Secretary Azar, there's been some misreporting that the block grant guidance is limited to adults in the expansion population. But under the administration's guidance, states could block grant Medicaid for more than just expansion adults. Isn't that true?
Congressman, I don't believe that's the case. I'll ask the CMS administrator to get back to you on that, but my understanding was that it would be an optional demonstration for adults only and that it would actually not affect coverage for our most vulnerable, our pregnant women, children, elderly adults, people on eligible on the basis of disability. But I'll ask Administrator Verma to get back to you on that because that is not my understanding.
Let me jump into this. I'm glad that you pointed that out because I believe that there is a concern here, and I hope that you would agree with me if that's your understanding, that you do something about it, Mr. Secretary, because the Center on Budget points out that people that are low-income parents, women who are pregnant, and people with disabilities who are covered through Medicaid expansion could be included in what I will describe as the President's illegal block grant guidance. Is that something that you would agree with if that's the case? Would you stop it if, in fact, the guidance does allow for those vulnerable populations to be discriminated against?
So I have been under the view that it does not affect coverage for our most vulnerable populations. It doesn't allow them to strip benefits, strip eligibility. Essential health benefits have to be covered. You can't change eligibility. You can't cap or limit.
So, Mr.
adult
Secretary,
enrollment.
if I may, just for clarification, because it sounds like we're on the same page.
What you're saying, I'm not, the concerns you're expressing, I don't believe
Mr.
are in the
Secretary,
HOA, but we'll get back to you on that.
Let me ask you this pointed question.
Yep.
If in fact the president's Medicaid block grant program does allow for those folks to be thrown off and get caught up in this, will you stop it?
Well, we're not going to approve plans that allow people to be thrown off because it can't change eligibility. It
Let me ask the
cannot change
question one
eligibility.
more
It's not
time, because
part
it
of the
sounds like you're
program.
getting there. Mr. Secretary, if in fact vulnerable populations like pregnant women, families, those that are disabled, are subject to this rule where they could be block granted, will you stop it?
I don't believe I will not approve a plan that removes coverage for our most vulnerable citizens.
So that's enough for me. You said you will not
I will
approve a plan.
with very low-income parents, children, pregnant women, elderly adults, or people eligible on the basis of disability should not be removed, should not be affected in terms of their Medicaid coverage, is what I'm informed. I'll get back to you from Administrator Verma to confirm all of those details. I want to make sure that I'm right on that, but that's been my understanding of the HOA program.
What I'm looking for is assurance that if what my comments are associating with being consistent with the center and budget points out, you in fact will not approve that plan, and you will not allow for Medicaid block grant cuts, devastating cuts, go into place that will be subjected to pregnant women, families, and those with disabilities.
The categories that I mentioned before are ones that I do not believe are subject to it, and plans should not be approved if they would harm eligibility for those individuals.
So if the Center on Budget's assessment is correct, you will not allow that to go in effect?
I do not believe their assessment or description of the program is correct, and I've said I don't expect that I would approve any plan that would harm our vulnerable populations. It is a healthy adult opportunities under Medicaid expansion, but we'll get you any clarification on that afterwards.
Well, thank you,
Appreciate
Madam
you raising that to me.
There's a reason that most of us in this Congress have opposed Medicaid block grants. These are devastating programs. It's another effort to undermine Medicaid and to continue to cut the program, which President Trump promised he would not. This is another example of where he is. And with that, I yield back.
The committee will now recess for approximately 20 minutes. So hold on to your seats while you stand up and stretch, and we race over and come back. Sounded like the secretary said yes, Ben Ray.
take a quick second to check it out. Yeah, let me get, try to get a second and check it out. Yeah, just a quick second. Okay, I'm good.